Hey, everybody. Welcome to our third coronavirus share and care brought to you by National Council on Severe Autism. Today's topic is preventing and managing severe autism behaviors at home. I am Jill Escher, and I am one of your moderators today. The other moderator is a member of our board, Amy Lutz, and we have two speakers. Dr. Matthew Siegel is the Vice President of Medical Affairs for the Autism and Developmental Disorders Services for Maine's largest healthcare network, Maine Behavioral Healthcare. He is a child psychiatrist and clinical researcher who leads a system of care for youth with autism in Maine that specializes in treatment of challenging behaviors and emotional needs. Dr. Gloria Satriale is an attorney specializing in special education and adult services. She holds a doctorate in special education and is a licensed behavior specialist. She is the executive director of Preparing Adolescents and Adults for Life, which provides educational adult habilitation and residential services. That's in Pennsylvania. The second of her 5 children is profoundly affected with autism. So this is how we're going to run this today. This is being recorded. So if you are concerned that you need to step out, you need to leave early, don't worry. Everybody's going to get a link to the recording of this event. We have had a number of pre-submitted questions. We're going to start off with those, and then we will begin to entertain the questions that you're submitting now. Now, what you do is you go to your control panel and you'll see a little tab called questions. All you have to do is type in your question there, and Amy and I will be monitoring those questions. And to the extent we can, we will pitch those to our presenters. We've allotted an hour and a half for this. It may go a little shorter, it may not, but just to let you know. Okay, so I think we should just launch right into this. And start with the pre-submitted questions. Now, I don't think that Dr. Siegel has video camera today, but we can hear his voice. So hopefully you will be able to hear him, and if not, we'll work on that. Okay, so I'm going to start off, and then Amy and I will alternate. We are on double lockdown. We are stuck at home because of Corona and afraid of our son's violence, which has escalated. We have not done much psych meds. He is 15 now and getting extremely strong. I just want something to keep us all safe. Assuming I can find a psych doc, what meds should we consider? I am not looking for something for long term, just something to keep him calm and nonviolent during this shutdown. Dr. Siegel?
Yes. Hi, Jill. Thank you.
Yes, we can hear you. It's all good.
Okay, good. So this is obviously a really hard time for everyone, and particularly our young people and not so young people with autism who, you know, their whole world and routine has been thrown off. And so it's not a surprise that for some of our people that they are struggling more than usual, and whereas you may not have had, you know, potential violence or other things before, it now may be happening or feel like it's going to happen, or it may be more intense or worse than usual. So generally, you know, as you said, the ideal thing would be you're already connected with a psychiatrist or other physician, developmental pediatrician, neurologist, etc., who can guide you on this and you can be in touch with. And because really the important thing is, as I think many people know, that usually the behaviors we're seeing, including violence, are often due to a co-occurring emotional challenge like anxiety or depression or something else. And in this case, anxiety, you know, is likely operating for many of us. And so that's what you want to treat. However, in the situation you're in right now, you're not going to be able to access a psychiatrist or other physician rapidly. You're not going to be able to get that full evaluation. And so this is really, a very difficult situation. So, the most important thing is actually not medications. I will talk about medication for just a minute, but the most important thing, I think, is I'm going to have our other panelists talk about in a minute, which is all the non-medication things that we can do to try to help our children and adults who are stuck at home during this situation deal with this, lack of their usual structure and programming. And I think, Gloria could speak some more to that. But what I will say is that in terms of, addressing an acute agitation, there aren't a lot of options. You can potentially try, if you have it at home, Benadryl, which is basically sedating, and that might be helpful in some situations. Otherwise, there really aren't over-the-counter medications that you could try. I know some people have asked, and we can talk about later, what are called muscle relaxants or benzodiazepines or Ativan, and we can talk about that in a little bit. So I'm thinking that maybe we can have Gloria comment some on kind of non-medication approaches to what you're dealing with.
Well, I'm going to interject for just a second, because this specific question says that this parent is assuming a psych doc and is asking specifically what prescription meds they could consider. I mean, could you speak to that? That seems to be central to her question.
I see. Okay. Thank you, Jill. I can't see the question, as you know, so it's hard to know exactly what it is. And as we speak, I'm trying to get our camera going. So that is a little hard to answer, because as I said, it depends entirely on what the kind of underlying issue is. So if it's anxiety, we'd be, looking at anxiety medications, potentially something like a Prozac or a Zoloft, if it is. And then more acutely for anxiety, some people will consider something like Ativan or Klonopin, which are sometimes also called muscle relaxants or benzodiazepines. And depending on the psychiatrist's evaluation, something in the atypical antipsychotic family could be considered like a risperidone or a Abilify.
Okay, let's move on. I have a feeling we're going to get a lot of questions sort of circling around this theme, but let's just move on for now. Amy, do you want to take the next one?
Sure. Our son seems to be doing better without school. He is less stressed and happier, and I am thinking of taking him out of school permanently because of this. But he is so loud, deafening loud. He yelps and hollers all the time. I think I'm going insane. He is not on meds, but help me, please. I need to bring this volume down. It is torture.
Do either of our panelists wish to speak to this?
Can you hear me fine, Jill?
Yes.
Okay, great. And do you have my camera now?
I can't see. Amy?
Yes, I can see you. I can see you, Dr. Siegel.
Okay, so there we go. So sure, I'll say a little bit and then see if Gloria wants to jump in. So it's not a surprise to me that some people are actually going to do better right now, and maybe in the short term, because of course school is full of demands and challenges, and so it could be, being at home could be a little bit of a honeymoon for some people. However, I would, while knowing nothing about your particular situation, I would be cautious about concluding that means you should permanently take your son out of school. It doesn't mean that necessarily that there's something wrong with the school program. It may be that school is a challenge for him because the educators are trying to help him move forward with his skills and abilities in life. So I would have a conversation with them about it and what does it mean that he seemed to do better at home without school, but I just wouldn't jump to permanently removing him from school. In terms of him being very loud, I think, I guess just repeating what I said before, this is a huge change, right, from what is usually a highly structured school program and maybe community program after school to now being at home with potentially very little structure. And so in terms of the loudness, I'm thinking that most likely that if that's not something you normally see, then that's probably a sign of stress and anxiety. And I would look to start to build structure for him.
Okay. So specifically about this parent's concern about just the ongoing shrieking or whatever it was, what did you say? Yelping. Do you have any specific ideas about how to address that specific issue, whether it's medical or not?
Yep, I do, but I was trying to give Gloria a chance to talk.
Okay, Gloria?
That's okay. Let's let Dr. Siegel finish, but I have a thought or two.
Okay. So my thoughts are pretty basic, but I think the basic can be really helpful for this situation, which is I would build him a schedule for the day, both an overall schedule and then subroutine, and show him what's expected and try to give some structure to the day. So we're going to start with, first is breakfast, and then we're going to go for a walk, if hopefully you're in an area where you can do that. And then we're going to come back and do some type of activity, something that perhaps he enjoys. But the idea being to give him a structure and give him a routine. And I would, either write it out if he can read or draw it out with pictures if he's a person who uses more of a visual schedule.
How does that help with the volume, though? I'm sorry to be pushing this. I don't see the connection.
Well, my presumption is the volume. So I'm assuming that, he's so loud that he's not typically like this. And so therefore it's a sign of stress and anxiety. And the way we reduce stress or anxiety for all of us is to get better oriented and have a feeling of control and knowing what's going on in our world. So building him a schedule and giving him some structure and routine in his day is going to lower his anxiety. And therefore, if I'm right, that he's being loud because of anxiety, then that loudness will reduce.
Okay. Would you have a medical angle on this or no?
No, I don't know of a screaming or a loudness specific medical piece, but so no, I would go after it with more of an environmental approach.
Okay. All right, I'll take the next question. What drugs can stop an aggressive meltdown in its tracks? My friend suggested Ativan, but I don't know much about this or other drugs, and I want to know about all the options.
Okay, so I started to talk about this a little bit earlier. So Ativan is what's also called a muscle relaxant or a benzodiazepine, and it can be rapidly. It's essentially an anti-anxiety drug, and it is also sedating, and it can act fairly rapidly, like 30 to 60 minutes, and it could slow down or help someone settle down from an aggressive or other kind of agitated state, but it's not going to work instantly and stop it in its tracks, and it may not, of course, work for everybody, but it is something that can be tried if you've had it prescribed by your physician for your child. Other things that could be tried, you know, again, under obviously physician guidance would be Benadryl, which is an over-the-counter. As I mentioned, sometimes people will give, if someone is on something like risperidone or Abilify, they will give an extra dose of that if their prescriber has said that that's okay. And again, it will not, you know, I'm kind of assuming that when you say stop it in its tracks, it will stop it instantly. And I think we all wish there was something like that, but there pretty much is not something that will work instantly, but it may help kind of calm things down over a 30 to 60 minute time period.
Okay, let's move on. Amy, can you take the next one?
So guys, can you hear me? This is Gloria.
Oh, yeah, please.
Oh, great. So I was having a bit of trouble getting my mic to mute and unmute. So I wasn't able to kind of jump in as I had wanted to with some comments. So if it's okay with the process, do you mind if I kind of back up and make a couple of comments? I think that Dr. Siegel, of course, is, you know, made a great point that, you know, unless there's some other pre-existing underlying yet undiagnosed or noticed comorbidity going on, meds are not going to prevent behavior. They may take the edge off, as it were, is our experience, and not to kind of get into your field, Dr. Siegel, for sure, but that notion of wanting to go immediately to a med to take the edge off. That is the first thing that I did when I noticed that this COVID thing was going into a direction that was going to lead to disruptions that we've never experienced in our lifetime of dealing with our children with autism. So the first thing I did was call the psychiatrist and said, okay, my greatest fear about this crisis is Nick will not be able to go to Wawa and get a Diet Coke. You know, we can do a lot of things behaviorally. We can kind of contrive that circumstance and hoard the Diet Coke and have it in our back pocket and go over to the Wawa and say, oh man, it's not open. Oh, look, Diet Coke, which may satisfy that piece of it and de-escalate him somewhat. I may need a benzodiazepine or something over the counter like Benadryl or something to take the edge off so that he isn't constantly in that state of agitation. So to have a PRN on board, if you have a pre-existing relationship, if you have a pre-existing, and indeed, you know, when we talked through it, I went directly to saying, do we need a benzodiazepine? Do we need an Ativan? How about, well, and we talked about Ativan, and I said, well, but excuse me, Xanax is more sedating. Should we go for the Xanax first? And then we turned it around and said, well, Zyprexa is a cleaner drug, and he's already on it, and it does have some, so that kind of a conversation is a great one to have if you have an existing psychiatrist. If the meds were a silver bullet, we'd all be in a much different spot than we are today. It's that intersection of the behavioral intervention and the drugs that can get us to a stable place. And then sometimes when we have that stability, we can maybe very systematically try to decrease the dosage or the polypharmacy to see if we can reduce that. Right now, I think, I believe it's not a time for that kind of trial and error, and it's not a time to try and do new things if we can help it. We want to try and be as stable as possible. In terms of the loud vocalizations, again, the detective work, this is why it's so tough on us when we say, well, what do we do about these aggressive behaviors? And Dr. Siegel kind of mapped it out, you know, beautifully in talking about the largest disruptions to their lives that they've had to date. And if there's low cognition, if there's, you know, limited vocal verbal abilities, I believe we're even in a more difficult spot to kind of get that ability to negotiate, mitigate, and have understanding. So we're left with detective work. Why is what's happening happening? And people, I think, I get sometimes crazy to say, oh, well, you need to take the data. What? With everything that's going on. So maybe it's not a take the data thing as much as it is be a detective. Why is he screaming so much now and he didn't used to? My mind immediately went to, in combination with he's doing better at home and than he was at school. Well, was school a little bit rough? I mean, I don't know. These are just all kinds of questions. Throw the spaghetti up against the wall and see what sticks. Maybe he was being reprimanded at school. And he now doesn't have that kind of, yes, it's punishing and yes, it's negative, but it certainly was a lot of attention. Maybe he's upping the ante now, that he's getting louder and louder more and more often, because what does always mean? Is it really always? And why is it happening now and not before? So that kind of detective work, what is the function of why he's doing what he's doing? If we can figure that out and we can replace it, we might be able to lower those vocalizations. If we can't do the detective work, then maybe it's all about, okay, and if you need a visual, you use it. Here's when you can scream, and you can scream your heart out. Isn't this great? Maybe, we'll scream together. I don't know. But this is when you can't scream. Some sort of discrimination training to, if he wants it maybe for a sensory stimulation issue. The environment's too quiet. It's not that lousy, crazy classroom or cafeteria or recess. I don't know the answers because we don't know your kid. And physicians and behavior analysts alike are ethically bound to not make specific recommendations and suggestions, only talk about things in terms of global strategies, because we don't know your child. And we're not in a position to do that assessment, that detective work, but maybe to give you some tips and strategies that after you do the detective work, then that's where that trial and error comes in, to see what can reduce what you're seeking to reduce or increase what you're seeking to increase.
Okay, I'm gonna just cut you off there. I'm sorry, but we have so much to go through, Gloria. So let's move on. We're gonna circle back to these themes several times. I have no doubt about it. All right, so the next question had to do with if you're living in a small space. And I think this has to do with what can you do physically with a setup of your small space if you live with a child who has violent meltdowns.
And you want me to address that first?
Yes, yes, please.
This is a common event, and it's just kind of escalated itself because of being in more often and for longer. You have to be able to work with what you've got. So that sense of frustration and anxiety that I know that I feel, I have to remind myself that, I have to accept the realities of what I've got, accept the variables I cannot change. So the small flat is a small flat. We have to carve out of that already small space a space that can be a safe space. And whether we're using bean bags or stuffed animals, we're going to make it a safe place. Because we're going to remove anything that is dangerous. We're going to make it a safe place because it's a place that I can still watch and observe. I mean, we don't really want to close anybody off, but I guess it depends upon the degree of what's happening. There have been situations where it's, okay, you're in this room and you stay in this room, and I know that you're not going to hurt yourself in this room. I cannot be in this room with you because then we're both going to be hurt. Then it might be a 911 protocol or some other protocol if it's that dangerous and that severe. But you have to identify that safe haven.
Okay, let's move on. Amy, can you take it?
The question is how to minimize screen time and keep autistic kids busy and safe when you need to work from home.
So I'll offer an initial thought on that. And some people may not agree with this, but my view is this is an extraordinary time that is, putting huge stress on both the individual with autism and the family and the person in this example, or with this question, who's trying to work from home. And I think the normal sort of desires we might have to minimize screen time or limit certain things, I think that we can ease off some on that. This is a little bit of survival mode, I think, for this month or months. We don't know how long this will go on for. And so, I think that our normal worries and understandable desires to limit screen time and have our kids be as productive as possible don't have to be quite as stringent during these times because they need to be able to be safe and entertained, and you need to be able to work and maintain your job. And so that's kind of my general response to this. Is this really is the exception. It is an extraordinary situation.
Yeah, I agree with that for sure. Let's move on. Please, no judgments. What about muscle relaxants? I think my son, who is very strong, might kill me or his sister.
So hopefully this is a judgment-free zone, and I think Gloria and I hopefully are conveying that we are all trying to do our best in a really tough situation, and that goes for providers as well. Just to say, I don't know what Gloria has been experiencing, but I and my staff have spent the last 2 weeks working 12 hours a day to flip all our in-person services into remote services and support our families and patients as best we can. And so I think we're all, so hopefully they're not judging how well we're doing it, and we're certainly not judging how people are doing, in this situation. So to try to answer your question, so muscle relaxants, again, are the kind of medicine that was referred to earlier as either Xanax, Ativan, Klonopin. They're all the same, actually. They just last longer or shorter. I don't think there's any judgment about if that is if that's what's needed and that's what's been prescribed and I would say overseen by your practitioner, then that may be what is helpful in the situation. All of those are not long-acting meds, so they may help for a period of time, but that may be what you need in this instance.
Can I ask you, Dr. Siegel, my son's practitioner just prescribed him a drug called hydroxyzine, which I think is an antihistamine. Do you have thoughts about that drug in particular?
Yeah, so thanks for asking that. Hydroxyzine is an antihistamine. It is very similar to Benadryl, which is called diphenhydramine. So hydroxyzine is very similar, and I think it is perfectly fine to use and has the same kind of uses as Benadryl, that it's a mild sedative. It's a mild anxiolytic or anxiety reducing drug for some people, and can be helpful, in the short term. Neither Benadryl nor hydroxyzine generally are helpful in the long term, but are more used, as Gloria said, PRN, meaning as needed medication. And I think and are relatively, benign or less concerning medications than some of the others that are sometimes used.
Okay, let's go on. Amy, next one.
Sleep. What are the best medicines to get my guy to sleep a lot?
Well, I can certainly answer, but Gloria, I'm wondering have you had good or bad experiences with sleep medicines?
Gloria, we can't hear you. I'll jump in for just a second and say that my son's practitioner prescribed him trazodone, which he takes at a pretty high dose. I believe it's 250 milligrams each night. And we combine that with melatonin, and that has helped him dramatically. I don't know if you can speak to trazodone, Dr. Siegel.
Sure. Well, I can speak to a bunch of them. So generally, so sleep is huge, obviously, for all of us, and we all do poorly when we don't have good sleep. So generally, kind of my sleep algorithm generally, or pathway is number one, before we get to medicine, don't skip over just, are we doing everything we can to make a good sleep environment or sleep hygiene, as they say? So, dark room, not too hot, not too cold, trying to not do stimulating activities as much as possible in that hour before bed, including screens if possible. And also not forgetting to have, if they wouldn't do it on their own, reminding people to urinate before they go to bed so that they're not awoken in the middle of the night to urinate. But that all said, then when you seem to need a sleep med, the kind of steps are usually melatonin first, because that's probably, as far as we know, fairly benign medicine and is helpful for a lot of people. It tends to be helpful to fall asleep. It does not tend to help the middle of the night awakenings or the early morning awakenings, but it can help falling asleep. And then after melatonin, it probably is trazodone, as Jill said, which is a more significant medication, but can be really helpful and is sedating and can help even into the middle of the night. Definitely trazodone needs to be overseen by a medical practitioner. And it is not over the counter like melatonin. So I'd say those are the two that are probably most used, and in terms of just to touch on, for evidence, there actually are a couple clinical trials of melatonin in kids with autism, which is a good thing.
One note on the melatonin, Dr. Siegel, I don't know if you'll agree, many sleep practitioners are saying that, melatonin is not a drug or a medication that you want to take when you are about to go to sleep. You're looking at taking melatonin 2 to 3 hours, depending upon your fall asleep pattern, prior to your regular bedtime. And that's a common, I think, I don't know if you'll agree, misunderstanding about the dosing of melatonin, and it is not effective if you're taking it. My bedtime's 11 o'clock. That shouldn't be when I go to bed. If I want to go to sleep by 11, in talking about the sleep hygiene, I would only add to the hygiene regimen. You're getting into bed 20 minutes to a half an hour prior to the, I want to be asleep by 11. Then I'm in bed at 10:30, and I'm practicing some breathing, and I'm practicing some mindfulness kinds of things. That kind of gets me to sleep by that targeted 11 o'clock. So if my target was 11 o'clock, I'm taking melatonin at 9.
Okay.
Yes, totally agree. Thank you.
Okay, let's move on. Okay, another question. How to cope and stay calm and sane and not argue with your partner in times when you have different views on managing children's problem behavior. So I think this is a question that's coming up in families, not just autism families, but quite a bit more bickering while people are sheltered in place. This is a little bit off topic to our webinar, but I don't know, Gloria, did you want to say something about working with your spouse?
That's a tough one for me.
You can pass, you don't have to.
No, I certainly can. I think I can say that, for many years, my son is going to be 30, I think. As we were moving through autism back in a day when there wasn't much out there about it, there was constant bickering, and it's very distracting. can eat up a lot of the energy that you need for other things. And we struck a place, and I'm not sure why, where then kind of my spouse wasn't involved at all. And then I was mad about that. And I realized much later on that it probably was good that way, because we'd probably be back in that bickering situation, and it would have been really bad. So what I think that we need to remember is, you know, it's not about me. It's not about you. Keep your eye on the prize. It's about the kid. And we may not disagree for each other in whatever our belief system is, but if we can agree on certain values and then agree to stay true to that value system, we want the best for him or her. You know, okay, what does the best mean? Independent skills, like try to find as much common ground as possible. Secondly, I've learned I don't need to, although historically I was intent on dying on every hill. Everything was important. It's not. So figuring out which ones of those hills that you really have to get into that fight about can probably be helpful. Also, it's detective work again. You know, I think we should do it this way because, well, I disagree. We need to do it this way because. Okay, let's figure out which approach gets us the best result, and figure out how you're going to measure that and how you're going to watch that and how you're going to observe that. Because if one way is better than the other for whatever reason, and there are many reasons, right? What's the stress on the family? What lengths do we have to go to for the child? It's extraordinarily complex. So mindfulness kinds of things, staying true to value system, and just trying to work together as a team, because it isn't about us, it's about the kid. I don't have anything better than that.
All right, great. I think what we'll do now is we're going to take we've had a lot of questions come in, and I'm sure that more will come in, and Amy and I will take turns pitching them from the question bar, but I'll start from the top. Dr. Siegel, for individuals on clozapine who need bi-weekly blood tests for the pharmacist to be able to dispense the medication, what happens in the present emergency when the needed blood tests cannot be performed? What are the risks of sudden discontinuance of clozapine?
That is a really good question. So clozapine is also called Clozaril, just for people to recognize that if they're using it. It is a antipsychotic and medication, and a very a powerful one, and sometimes a very helpful one. But it is a medication, whereas the person writing the question is saying, it is, I believe, the only antipsychotic where you are required to have regular blood draws to monitor the person's blood counts to make sure a uncommon but potentially serious side effect doesn't occur, where your white blood cells can go down. So there is a very strict system around this medication, where you have to get blood draws to check your blood, to check the person's blood counts on a frequency. That frequency goes down over time. So when the person first goes on the medication, it's typically weekly, then bi-weekly, then monthly. So anyway, here we are in this situation where it may never be easy to get a blood draw for your child or adult with autism, but right now it could be exceedingly difficult. So there is actually a little bit of good news, and I don't have the detail in front of me, but the government and the company that runs that monitoring program has loosened the restrictions on Clozaril, and there is still a requirement to get blood draws at a certain frequency, but they have extended the period of time and made it easier to meet that requirement. So hopefully that will allow you and others to maintain staying on the medication and to get the blood draws as needed within that schedule. I will say there are a lot of labs, the laboratories in my state are still open because they're healthcare services, but certainly I can understand it might be harder to get that done. And then just to say again, that is not a medication to suddenly stop. And so I would make every effort and I would be in touch with your provider because that is also typically not a medication that we end up using unless it's really needed. So I would just, but I feel for you in this situation, and hopefully that flexibility that was just announced in the last week by the FDA will be helpful.
Thank you. Amy, would you like to take the next question or pitch it?
Yes. So Dr. Siegel, one of our listeners wants to know if you offer telehealth appointments, if you are taking patients online for prescribing medication, or maybe you can speak more broadly to this option going forward as people are struggling to try to make some medication changes during this difficult time.
Wow, well, thank you. That's a very nice question. So I myself am not. I have my existing patients who I see, and so I'm not. I think you're asking, would we do telehealth to somewhere else in the country? That's not something we're doing, but we are doing telehealth appointments for our current patients and new patients, and we're actually doing it both by phone and by Zoom video, but we prefer Zoom because it's more information and a better modality. But of course, some of our families, that doesn't work for them, so we're also doing telephone appointments. There is good news in that world, which is, frankly, the United States has been very slow to develop telehealth abilities prior to this crisis of COVID-19. Many insurers have not supported it. There's been a lot of regulatory barriers. I think, just tracing back to the fact that seeing your doctor or other medical provider, nurse practitioner, et cetera, is still billed and documented and based on the old idea of you go in and you get a physical exam and you see your doctor. And so anyway, things have been really, I think, unnecessarily burdened in that area. However, this crisis has forced a lot of rapid innovation and relaxation of rules and regulations. And so I think that if there is any upside to this situation is that it is forcing innovation. So a long way of saying we are doing telehealth appointments with our current patients. However, I'm guessing you don't live in Maine, and so we probably can't do it for you. However, many other providers are doing that as well and have been forced to do that. And so I hope you can access someone who is in your region. And some are certainly even starting, initiating new patients through telehealth. So I would call those clinics and see if you can get in with a telehealth appointment.
Okay, thank you. Moving on, I'm going to give a pair of questions to Gloria here. Do you have any resources for modifying the home, such as wall padding, non-breakable furniture, for individuals who engage in high levels of property destruction or self-injury? And then similarly, here's another question. How can I keep my 5-year-old safe from climbing everything around the house? The moment you stop him from one, he is already on another. So any thoughts about basically structural modifications to keep people safe?
Okay, so yes, we do all of that stuff here, and sometimes you order things on Amazon. Sometimes you repurpose things in your own house. My son's wrestling mats are now, here to provide cushion for the floor. And you can do that with mattresses. You can do that with air mattresses, regular mattresses. Big stuffed animals become, that kind of blocking soft pad between you and the your child, or your child is able to squeeze those big stuffed animals or big decorative pillows. You can make sure that all of your corners are covered, and you can even you can do that. You can certainly buy styrofoam corner cover things. I don't know what they're called right now, but they do exist, and they're made of foam. There are pads for poles that they use on goalposts. So a lot of commercial athletic equipment can, whether we can get this stuff now, or you can use things in your house to duct tape around a pole or duct tape onto a corner, or you move that table with corners into the attic or out into the garage. So if there's a 5-year-old that's climbing on everything, which is, I guess, a toddler issue as well as an autism issue, and I'm far removed from the toddler world, but I would put up pet gates. I would put couches in front of stairs, access to stairs. I would empty rooms. I would go outside if I have a pool and look for my pool mats and my pool noodles and all of those things to repurpose them to make sharp edges dull and to block open spaces.
All right, let's move on. Amy, would you like to ask a question?
Yes. So here's another medication question for you, Dr. Siegel. My son's anxiety rose 1 week before the coronavirus closings. He's developed a facial tic and it's progressively gotten worse. The doctor has raised his medication, but I'm wondering what other non-medication techniques I can use. So maybe Gloria, you can jump in here too. He goes between fits of crying to just shutting down on me.
Okay. So one thing to say is so tics are, brief motor movements. Eye blinking is the most common one, but it could be any motor movement. And just one thing I wanted to say, because it can look concerning, but tics in and of themselves are not dangerous. So I don't want you to focus on the tic too much or worry about it. I'm not saying it doesn't look concerning or is something you want to be happening, but I don't, generally the message is almost most tics are not a problem in and of themselves. They are, as you were, I think, pointing out, a sign of increased, tics go up when anxiety goes up. Or when distress goes up, and so that's what's going on and what's causing this. So without knowing more, it's hard to say from a medical perspective what could be helpful. But I at least wanted to provide the reassurance that the tic itself is not, I think, something to worry too much about, and most likely will go away or go down once the current stressors are past. But also, as Amy said, I think there are probably some non-medical approaches.
So did I hear, because I couldn't hear the whole question, was it that we're moving rapidly through emotions, crying and shutting down? Is that what the non-pharmacological and medical reasons that's happening, and what could you do while it's happening? Try to redirect the behavior, try to increase the availability, non-contingently, like for whatever reason, you just have lots of great stuff out that the child likes, so that maybe the child will access something that they're very, very interested in. Of course, to increase the value of these things, you may not want to have the most favorite items out all the time. You know, maybe just in times when, you know, you seem to not, the crying is inconsolable. If it is a behavioral reason, if it's a sadness, if it's a disconnectedness, I mean, I don't know, but maybe we need something that we really love and we really value. So if that's available, maybe that would be some consolation. Again, with the detective work of finding out, you know, the reason for that behavior, is the child not getting enough attention and they're upping the ante, so that you can then, you know, shower them with attention and just try to watch to see if any one approach that you make is giving you the desired result, and then you would have the answer and be able to modulate that.
All right, we're going to move on. We have so many questions. We're going to squeeze in as many as we can, people, so we'll do our best. We've had a couple on specific medications, and I do want to make a comment, which I think it goes without saying, that nothing on this webinar is medical advice. You have to consult with your own practitioner about your child's individual needs. This is just basic information. And also somebody wrote in, a mom wrote in saying, hey, you know, just be aware that drugs affect different children and adults in different ways. And there's no kind of broadly applicable reality to these drugs. And I think we already know that, but it is worth emphasizing that. Okay, anyway, back to our program. Okay, so this mom asks about, what is your opinion on propranolol, which is something our team had talked about earlier. And then another mom asks, is it okay for a person to be on clonazepam daily? What are the long-term effects of daily use? So 2 drugs. Dr. Siegel?
Okay, so propranolol is what's called a beta blocker. So it generally slows the heart rate and can lower agitation and anxiety in some people. There have been some various studies, smaller studies in autism over the years. There was one recently that Gloria and Jill and I were discussing earlier. I think we don't yet have a what we'd like to see, which is a large kind of strong study of it. However, there are some hints that it could, I would say, kind of hints that it could be helpful for some people. However, it is not a drug one can start. Well, I don't know if there is a drug one can start on their own, but this is definitely not one. It can drop your blood pressure significantly, and the studies where there's a hint that it could be helpful are using what are relatively high doses, actually, of propranolol. So I think it's something that is interesting, and there's a lot more to learn about it, but certainly something you could discuss with your medical provider. I know, Gloria, you mentioned earlier you had your own, I think, positive experience with it. Sorry, you're muted, Gloria.
Okay, there we go. Sorry about that. It's not my computer, and I'm not being very fluent here. I did have a very good result with my own son, Nick. And it did stem from, he's an extraordinarily complicated and can be extraordinarily violent young man. So we had a very good handle on these aggressive behaviors, what the antecedents were. We had a very good handle on all the data. And all of a sudden, one day, things really started to trend in the right direction in terms of these behaviors, frequency, duration, and intensity decreasing. We had not done, the only variable was the propranolol. We did something that I probably wouldn't suggest because it's not something that is recommended. We did a reversal to try to see whether or not that really was that. So we took the propranolol away. And we immediately got a spike once again. So if you are working with your healthcare provider, if you have someone working with you who can tightly control a study to ensure that this is having a positive effect. We weren't after it for this reason. His blood pressure really wasn't only slightly elevated, and we were only looking at that because of a side effect of another medication that he was on. So we came about it quite by accident and worked very carefully and closely with the cardiologist and his board certified behavior analyst to kind of ferret this out. And that's the only way probably any of this should be approached when we're looking at meds. But yes, I had a very positive result and he continues to take it to this day.
I have a quick supplementary question. So my son's doctor had prescribed him bisoprolol. Is that the same as propranolol?
It is, I believe, it is another form of a beta blocker. So it's not the same, but it is the same kind of medicine. It probably is just not as long, it probably lasts not as long. And that's off the top of my head, but
Okay.
yep.
So Dr. Siegel, a lot of these medications that we're talking about are classes of meds that have the same trajectory, the same way that they work, but there are little differences between them, and because of metabolism and individual responses to medication is why we kind of sometimes cycle through them. Would that be accurate?
What did you say at the end, that we sometimes what through them?
Well, sometimes we'll be on one beta blocker, for example, and then move to a different beta blocker, or on one benzodiazepine and then move to another to see if there's our body is metabolizing it or reacting to it differently, but it's still within the same class of medication.
Yes, yeah, I think that's right.
Okay, Amy, would you like to take the next question?
So there are a couple questions that such as this one, which is, my son is struggling so much right now. He is 19 years old with severe behavior. We have tried many meds, but he seems hypersensitive to them. Have you ever had a kiddo like this, and what would work? Lots of anxiety, which ultimately leads to lots of challenging behaviors. So what are the non-medical ways of dealing with severe aggression, self-injury, if any, that either of you have found to work?
So I'll just maybe start off, and then Gloria could follow that. So I think the question threw in there that it seemed to the person that, again, I love what Gloria keeps saying about being a detective, because that's what it's all about. But in this case, it sounds like the detective story has shown that there's anxiety there, and that's driving these, and likely that's driving these dangerous behaviors. So if that's the case, then yes, we can treat the behavior with different behavior management approaches, but we got to go after the anxiety and hope that will generally reduce the propensity to engage in the behavior. And so so of course, and it sounds like this person has tried many medications and they haven't been helpful, or their son, I think, is, you said was sensitive to them. So, but there are many anxiety, non-medication anxiety treatment approaches. So depending on the cognitive ability of the person, if they have higher cognitive ability, as probably you all know, the best evidence approach is cognitive behavioral therapy. That does, in its classic form, require usually someone to be verbal. However, you can take the principles of cognitive behavioral therapy and emphasize the B, the behavioral, and less the C, the cognitive, even for our more severely affected kids and adults. And so as an example, come across this situation multiple times where a person is engaging in aggression or self-injury, and after that detective work and some good observation, it's noted that it tends to be upon entering an area where there's a larger group of people. And at first we might have thought it was a demand problem because it's a music group or something, or maybe it's too loud. But really, after a while, we figured out, okay, it's really entering any crowd situation or group situation. And so we interpreted that as social anxiety and some social phobia. And so then the treatment there is can be a behavioral one, and this is an individual who did not have language, where basically with any anxiety or fear, what you do is slow, small approximations to build up tolerance to the feared thing. And so we did kind of small, slow exposures, if you will, to group situations, and while giving the individual lots of reinforcement and praise for what they're doing and the ability to escape that situation when it became too much. So I'm describing kind of a particular situation, but it's a general approach to anxiety that can be taken that is not medical, it's behavioral, and I think has very strong evidence behind it.
All right. Was there a second part to your question, Amy? No. Okay, I lost you.
No, there wasn't a second part to the question.
Okay, I'm sorry. I'm going to go on to the next one. My 3-year-old was recently diagnosed with moderate autism. He displays echolalia. He uses it mostly as a comfort tool. He will sing nursery rhymes repeatedly during a stressful situation, for example. We are on waiting list for speech therapy, but it's happening more often. Is there anything we can do to slow it down, or do we just embrace it? We are very new to this.
Well, there's nothing wrong with embracing everything that you can, because it's not a sprint, it's a marathon. But after a while, these repetitive behaviors, whether it's scripting or any other repetitive behavior, can kind of become unnerving. So if you are patient and if you can embrace it and it's fine, it's certainly not dangerous. It's certainly not anything that is going to, we kind of have a rule. Now your child's a little young, but the population we deal with mostly are individuals anywhere from 12 to 30 plus. So by that time, any of these kinds of unusual behaviors really serve some sort of purpose for that individual. It has a function, like you said. He really seems to enjoy it, and enjoying something is great. So we believe that if the behavior does not harm yourself, harm others, is so stigmatizing that it excludes you from the community, prevents you from learning, or prevents you from working, have at it. Like, this is great. Enjoy yourself. It's quality of life. The trick becomes when we put the scripting aside so that we can do other things, whether it's going into the community or not. And that's that thing called discrimination training. So if you kind of look that up and look at some of the suggestions on how you train when it's okay to engage in this and when it's not okay, and there's tons and tons of approaches. And it comes back to that detective work. The detective work is to figure out why is the kid doing this. If you're doing something and I give you a piece of candy and all of a sudden you stop, he has access to that. Okay, well, I know that stopped the behavior. Did giving you lots of attention stop behavior? Did giving you choices behavior? Did leaving you alone and ignoring you and really ignoring you stop it? If you look more and more into what is called functional analysis, and I'm going to look for a resource for that, because I don't think, and I wanted to mention in case we forget, there's a PowerPoint that I sent. I don't know if we are going to put it on our website here, but it certainly can be found on the PAL program website. We became increasingly frustrated with The resources that have been coming out are fabulous and wonderful, but we did not feel that they really spoke directly to the more severely affected population. Things talking directly about what are tips and tricks to prevent aggressive behavior. What happens if the aggressive behavior comes? What do I do now? Those kinds of things. There's a lot more in there than that. There's also additional resources, but you could go to that as a beginning and then expand from there. And I think you'll be able to know how to do this detective work a little bit better.
All right. We've had a lot more, questions about meds, so I'm going to go back there. Here are three. I'm going to throw them into one question. One asked about melatonin dosage, whether 10 milligrams is appropriate. And of course, I don't know the age or size of the child. That's the first. The second one is Repurpose. Is that helpful in this situation? Nudexta. And then I don't know what this is, Rauwolfia serpentina. So Dr. Siegel, sorry, I threw a bunch in there.
That's all right. So a couple things. So melatonin, we are very lucky that the hard work has been done to do some studies of melatonin. And when I say study, I mean the kind of classic placebo-controlled study with 40 or 60 people participating. Those studies almost entirely, I believe, use doses of 1 to 3 milligrams at night. So that is the typical dosing that is recommended for melatonin. There are people who use higher doses, 6, 9, 10 milligrams. And when I say people, I mean practitioners prescribe that. But I would say in terms of the evidence base that's published in the scientific literature, it focuses on the 1 to 3 milligram dose. I will say that just from my personal experience, that's different than studies and evidence, that I have never had a kid who, or a young adult who wasn't falling asleep at 3 or 6 milligrams and did at 9 or 12 or 20. In other words, I haven't seen that going to a very high dose is helpful. I also personally, because of the way I practice, would be not willing to do that because that's again not where the evidence base is. That said, there is another form of melatonin called controlled release or long acting. And I think that typically does come in more of a 5 to 10 milligram dosage. And there has been one recent study on that. So in that case with the controlled release, I think that the dose is higher. But for general melatonin, it's more like 1 to 3 milligrams. And as Jill said, also can depend on the child's age and child or adult's age or size. I have to say the other 3 medications, and it's always hard because medications have 2 names, annoyingly. It's generic and it's brand name. I did not recognize, I think, any of them, certainly not the wolf serpentine thing, but that sounds concerning. And I might be really cautious, whatever that is. The Nudexta I just didn't recognize, and the Repurpose I do recognize, but I'm having trouble calling up. So one thing I will say is, I like that Gloria mentioned resources. So I do have, I think, what is a good balanced resource for people, and it's free, and you can download it from the internet. So we're all stuck in our homes or offices, and so you can still access it, which is, there is a parent, it's called the Parent Medication Guide for Autism Spectrum Disorders. And it is on the website of ACAP, the American Academy of Child and Adolescent Psychiatry. So it's www.acre.org. aacap.org. And then if you search for this parent medication guide for autism, and I like two things about it, and I am biased because I was part of writing it, although it was written by a large group, but there's two things I like about it. Half of this book about medications is not about medications. It's about all the detective work and thinking about what is going on with this person, and should, is medication helpful, or are there other things that could be helpful, which I think is an important process to go through. And then what I like about it is that it's free and available, and that it addresses a whole series of behaviors and gives kind of the evidence for different medications. And it was written for parents, so hopefully is fairly readable.
We can
Dr.
put a
Siegel.
link to that in our notes when we post the link to this webinar.
Dr. Siegel, do you have any guidance on whether you think the sublingual dosing of the melatonin makes a difference?
I do not. I'm not aware of any evidence that it changes makes it better or worse. I just don't know. I don't see any problem with it, but I just don't know.
Okay, great. Amy, can you take it away?
Okay, so this question I would probably shoot to Gloria first. This is from a teacher for young students who is looking for some supports to offer parents that require a little prep and setup. She says, I know that most of her parents would like to limit screen time, but I know we've already talked about that doesn't really need to be a priority at this moment. But I guess she's looking for what she calls quick supports. I've sent them visual schedules and first then schedules. But I know we're all trying to keep our kids busy. Do you have any suggestions or online resources you might be able to recommend?
So the online resource has kind of exploded. We haven't been able to keep our finger on it because we have been suffering the same fate as Dr. Siegel has. Providers have really been in a tough spot right now. But I can say this, that again, it's kind of when Dr. Siegel was talking about forced rapid innovation. Creativity is key here, and to not really kind of to put too much thought into it. I was sent a text picture about kids just going crazy on the sidewalk with a sidewalk chalk. If the weather is cooperating, and maybe it's not a strict structure. Some structure within the schedule is good, but maybe it's blocks of active time where there's just some sort of activity and there's a bunch of choices, and that bunch maybe is only really 2 or 3, but it's like, okay, we don't care what's happening right now between 1 and 1:45, but we're going to do one of these things, and those things can be anything from depending upon how much adult supervision is necessary here, right? Whether it's baking or going outside or even screen time, but interactive screen time. Some of our kids that are really into these games and things, people talk to you if you have a headset. There's a resource, and it's linked in the PowerPoint. Let me see if I can find it right quick. That is the single most comprehensive resource that we have come across, because we did a little bit of research when we were trying to put our PowerPoint together for our tips and tricks for individuals with severe autism. So everything that we have found is in that PowerPoint. Oh, it's slide 62. I see you have it there. So it's University of North Carolina, I think, but it's called Supporting Individuals with Autism Through Uncertain Times. It's not easily navigable. The resource is huge, and each link is linking you to something else, which is linking you to something else in domain areas, but there's visuals on there. There's activities on there. I would suggest that you go and watch the NCSA webinar that was yesterday, which talked specifically about activities and what can we do, and what do you do when you're cooped up.
I was about to mention that, and we posted multiple links that were mentioned during that webinar. All you have to do is go to NCSA or ncsautism.org/blog, and you will see a whole bunch of links from that Activities at Home webinar.
The other link that might be a good one in terms of ready-made, ready to go, simple, easy. It's theautismhelper.com/emergency-home-school-kit. So
we'll try to put these things in our show notes.
Yeah,
Okay.
like I said, it's the PAL program website has the PowerPoint on it already. It is slide 62 and 63 has all of the links to all of these different resources.
Got it. Okay, we'll include that. All right. Let's see. We have a couple more minutes here, so I'm going to. Oh, some people sending me that. My son's anxiety comes out in the form of perseverating and worrying about the weather. He needs constant reassurance that it will not thunder. This goes between looking outside the window, asking for reassurance, and asking to check the weather app. How can I help him during this time manage this behavior now that it is increasing due to the stress and anxiety during this difficult time? It's a very specific question. Do either of you want to try?
I think it has a lot to do with problem solving. I think it has a lot to do with accessing resources. I think it has a lot to do with trying to understand what's underneath the worry of the weather. There's probably some OCD and anxiety, but that would be Dr. Siegel.
Thank you. That's good. So what I'm struggling with is, so I really like treating phobias and fears, and again, going back to the CBT approach, cognitive behavioral therapy, there very strong evidence on how to do it, and so the way I would want to treat that in a normal situation, which I don't think you're going to do in your home, but just I think it's worth saying generally, is with our normal reaction to any fear or phobia, particularly when our children are experiencing it, is to shelter them from it and to avoid, right? And the problem is that when you avoid or shelter someone in the normal situation, that makes the anxiety or fear or phobia go up and get bigger, not smaller, because by sheltering them or avoiding it, we are giving the message that it's real and that there really is something to worry about. And so the approach would be to do a slow exposure. So, you might get a video, I think it was thunder or lightning, which is a very common fear in autism and elsewhere. You would show brief videos of lightning or thunder and put it in the child's control and let them expose to it slowly. Now, that, and probably under the guidance of a therapist who's trained in cognitive behavioral therapy. I don't know that we want to do that right now while you're stuck at home with your child. That would be the kind of general treatment approach. So one thing that occurs to me you could try to do in the situation you're in is, and Gloria brought this up with a different behavior earlier, which is try to see if you can give it a budget. We have worry time and non-worry time. So there is time when we can talk about lightning and thunder and have our worries about it. And then there's not that time, and try to give so in other words, give permission to talk about it and worry about it on a budget. So we get to do that every other hour or 5 minutes of each hour or some frequency that seems to work for your child. So that's kind of a quick thought in terms of in the situation you're in right now, where you probably don't have great access to therapists to work on this long term. That would be one way to try to address it.
One direction I thought Dr. Siegel was going when he talked about slow exposure, it's called desensitization. So if you were giving that slow exposure because the idea was of fear, you know, and everything is okay, and to just incrementally show that everything is okay as you are desensitizing to whatever that fear is. If it was a compulsion, that the approach might be a little different. And then I also wanted to take the opportunity to ask Dr. Siegel to comment, since he was talking about CBT. We've been using a lot of DBT lately, dialectical behavioral therapy, which has a lot of the same components, but there's a behavioral aspect that kind of connects into doing the work and having control over your environment and being in kind of, you know, you've got the power to affect the change. I didn't know if maybe you wanted to talk about that, because that's being used a lot as well.
I don't have DBT is an important treatment approach. I have not had much experience with it with the more severely affected population, but I would be interested in how people who are trying to use it with our folks who are more cognitively or language limited. Kind of the classic form of DBT can be quite abstract and need you know, someone who maybe is less severely affected. But I wonder if either you or others are doing adaptations that you have found useful.
I think I can't see the video, but I don't think there's an answer from Dr. Satriale. Let's move on, because we're almost towards the end of our time period here. Now, I did get one by email that asks about an area that I'm very interested in, of course, and it's why hasn't anyone brought up medical cannabis? It has been a lifesaver for my adult son. And then it goes on, but I won't go into the details. Dr. Siegel, did you want to try?
Sure. So, of course, there is huge interest in medical cannabis, whether it's CBD or THC or combinations, in the world and across the country. And there's definitely been a lot of interest and use in the autism population. There are several trials. What I mean is studies, clinical trials going on currently. Jill, you're probably more up to date than me, but I don't think we have results yet from any of the larger studies.
Just some very, very preliminary results from Israel.
Okay, but we're all, certainly I'm waiting kind of on the edge of my seat, as well as others, for those results, and hopefully those will be well done studies, because I get asked about this every day. So, you know, as you may have picked up from some of my comments, I'm a fairly conservative prescriber and kind of approach to medicine or chemicals, you know, and so, you know, I want to see studies and evidence before it's something I'm going to recommend to people. And we're not quite there yet with marijuana. Of course, there are many people who have had positive experiences and many who have not. You know, I've had many patients or families who have tried it and not getting it from me because I don't prescribe it, but or they just get it, prescription or not. And some feel they've had good experiences and some have not. And so, but it's I would say it's a very challenging area, not just from a provider standpoint, not just because we don't have the studies or evidence yet, but also because depending on where you live, it can be very highly variable what the person is taking. So, you know, what dose is it and how much is in it and et cetera. And there are places where that is reliable and lots of places where it's not. And so, of course, that makes physicians nervous. I think many of us nervous. So I think more to come, but, you know, that's kind of where we are, and certainly why I didn't bring it up so far. But I think lots of people have opinions on this.
Yeah, they do. There are parent groups where people trade what really is nothing more than anecdotal evidence, both positive and negative, like on Facebook. And yeah, that's a place to go for at least some basic information. But yeah, there's not much clinically proven at all. Amy, do you want to take the last question or two? Do you want to ferret out one or two that you'd like to pitch?
Well, I would, if it's okay. I have a question I've been waiting to ask.
Yes.
It's for Dr. Siegel. So, as you know, my son is kept very stable with electroconvulsive therapy, a combination of ECT and medication that he's been on for 10 years. And now what's being filtering to me back through my kind of network is that because of the virus, some access to ECT is being kind of restricted, possibly to shut down. And that hasn't come up for us yet, but I'm absolutely terrified of what would happen. So maybe you could speak to not just, this is, I know, a kind of a niche question. There aren't a ton of families who use this therapy, but what to do if your go-to therapy suddenly becomes inaccessible because of, because of the changing landscape. What are our options?
Yeah, so it's completely terrifying. I was just sitting here in this office talking with one of my colleagues who works in our center who has a patient or a child who has been receiving ECT for months, and it has been life-saving for that child. And access has not been cut off yet here in our region, but it's getting restricted, understandably, because no one wants to, have more exposure to other people than they need to, and medical settings are trying to be careful about what they do. So it is totally terrifying to potentially lose access or have restricted access to that treatment or any other treatment that has been helpful, or lab draws like we heard. So I don't know, it's such a broad issue or question. I'm not sure, really how to answer it, except to say I think we have to continue to advocate for how important access is to our various treatments, and plan ahead, and let people know that we really need to have the access, and we need is there any alternative if something does change? But I'm sorry, I don't have a kind of a better answer than that.
All right. I think let's just hope that all families in our community can get access to the therapies they need during this difficult time. Let's hope it doesn't impede the progress that we're making, and that hopefully we can find solutions, even if they're short term, to help all of our families that are going through this trauma. We are at the end of our time, and I regret that we couldn't get to all of the questions. We will post a link to the recording of this webinar, and also once I get all of them, we can compile all the links to some of the resources that have been mentioned. I want to thank our panelists today, Matthew Siegel and Gloria Satriale, and thank you, Amy Lutz, as well, for helping out. And at this point, I'm going to sign off. Thank you so much, everybody. Appreciate your participation today and all the really great questions.
Thanks for having us.
Thank you.
Bye-bye now.
All right. Bye-bye, everyone.
Bye.